Let's make sure everything looks good. Sounds good. Okay. Just going to double check over here on YouTube. Make sure everything sounds good. I think it does. Yeah, it sounds like it's okay. So that sounds good. Keep it there for now. Just share this on Twitter and we'll get going. Okay. Almost there. So sorry for the delay. Okay. So I think everything sounds good, looks okay, and that means it's time to get going. All right. Well, good afternoon, good evening, whoever you are, wherever you are. My name is Dr. Patrick Lockwood, and this is yet another episode 66, I believe, of UnShrink Me, a weekly podcast dedicated to you, the regular person who seeks out therapy, counseling, mental health, psychiatry services. So this is a weekly podcast hosted on my YouTube channel. And the goal of this podcast, if you are brand new to the UnShrink Me universe, is number one, to try and provide a reasonable critique of the trendy things that are happening in mental health discourse. And number two, make it so that you get better help from the people that you're currently seeking help from. So this podcast is mostly dedicated to the consumers of people seeking out mental health services. And as always, although I am a professional, I am a clinical psychologist here in the state of California, I am not giving you, the viewer, listener, commenter, specific clinical feedback. This is not a professional relationship. I am not your shrink. Thus, it is called UnShrink Me. So please do not sue me. And if you do want to sue me, feel free to just cancel me. That would be much better than suing me. So feel free to do that. As always, I really appreciate everyone who comes out to chat, to like. And if you are new, my content that I talk about every week on this podcast usually comes from Twitter, now called X. And my handle on Twitter, if you'd like to follow me, tweet at me, and so on and so forth, is at AlobhaPatrick, at ALOBHAPATRICK. So you can come follow along. Every week I stream on Saturdays. I also retweet the things that I'm discussing on this podcast so everyone can follow along and see exactly what I'm discussing and fact check me and keep me accountable. So follow me on Twitter, follow me on YouTube. My name on YouTube is Dr. Patrick Lockwood. This podcast is part of the Greater Psychology Checkup world, and it's great to have you all here. As always, this podcast is not not, but maybe someday, sponsored by Celsius. Hey, Angie, glad you're here. I knew you would show up. In fact, you even said you would show up today, so glad you're here. In fact, one of the reasons why Angie is here is because we spoke about this earlier today on Twitter. So I have three main topics for today's podcast. Topic number one is psych meds. Thanks to our friends like RFK Jr. and the Maha folks, there's all this chaos about psychiatric medications. Are they going to disappear? Are they going to be outlawed? Blah, blah, blah. So we're going to talk about that. Club XL Jeff says, the Greater Psychology Checkup world. Yes, I have lots of content on the Psychology Checkup, my YouTube channel. And so feel free to check out all the other videos I have, Jeff. Feel free. I have non-psychology videos. I have videos of me playing the piano for whatever it's worth, if you're interested in that. So anyways, topic number one, the important primary topic for today is what is up with psych meds? Are they good? Are they bad? How are they useful? If they are useful, so on and so forth. Topic number dos for today is a little less spicy. I want to talk about what do you do when you notice that your therapist is unhinged or unwell. And number three, I want to talk about the so-called inner child and what that is and is not, and what might be happening when a therapist or other professional talks about that. So those are the three main topics. Other things might show up. Thank you again to everyone who is here in the chat and talking and checking in and sharing and commenting and all these things. So grateful for you being here. So without further delay, let's start with the topic du jour, which is what happens with psych meds if they're deprescribed. And I happen to have someone who is deep in the middle of this world professionally on the chat with me right now named Angie Peacock. Very glad you're here, Angie. And so I welcome any and all feedback you have in particular, because not that other people's opinions aren't important. However, since you do this for a living and you help people, I think you will have very reasonable things to say in response to whatever I'm about to say. So let me just retweet something real quick, and then we will start our podcast about the problems, let's say, of psychiatric medications. So I actually want to start with an older post on May 2nd. So this is about a week ago. This is from a person that I have never interacted with in my life that I'm aware of. His name is Kevin Roy. So I'm going to retweet his post real quick, and then we're going to dig into the topic du jour. Okay, almost there, so sorry. All right. So on May 2nd, about a week ago, Kevin said the following. And by the way, his handle, if you're interested in knowing who he is at KEVINRO903214458. Interesting. So he said, and I quote, "Psychiatry is a 3-point triangle that keeps people trapped in a prison. Number 1, the psychiatrist. Number 2, the drugs. Number 3, the idea that you are mentally ill. If you play along, you are the ball stuck between the 3 sides. There is only one answer. Recognize it's a construct, mental illness, and when you do, you can start to heal and begin tearing it down." So Kevin's post here is actually something that relates to another post that I'm going to discuss, but I just want to start here with Kevin's post because I think it speaks to something very important. So this triangle he describes, the triangle of the psychiatrist, the professional, the authority, as it were, the drugs, which have their own authority and like industry behind them, and then the concept of mental illness, which obviously has its own industry behind it. So there are 3 wildly powerful forces: the concept of mental illness, the concept of psychiatric medications, and the concept of a helping professional. I think he is correct. Kevin is correct when he says that these 3 forces can feel like a lot to a person who is struggling. So for people who may be struggling with whatever is happening, whether it's a mental illness or not, these 3 forces are very important to be aware of, because all of us feel some pressure when we talk to someone that we consider a higher status person, a person of privilege, a person of prestige, a person with an advanced degree, a person with a certain status in society. And unfortunately, in my opinion, people like myself and like psychiatrists often have an unearned prestige, I would say. And something I say all the time in this podcast is we are just regular people too. The drugs. The drugs have this mythology around them, which I'll spend a lot more time talking about in just a little bit. But it's important to say that psychiatric drugs are not a very simple thing to understand. Psychiatric medicine, psychiatric drugs, however you want to describe them, are not like this one-size-fits-all, easy-to-understand thing, right? So because society has certain stereotypes and norms around psychiatric drugs like SSRIs or anti-anxiety medications, implicit in them is this idea that something is wrong with you. So if you're taking these medications, it automatically has the connotation that something is wrong, right? There is something problematic about you, whether it's you have an illness or you have a stressor you cannot manage, but you have a problem. No differently than if you had like a cold, essentially. And then number 3, which relates to that, which is this concept of mental illness more broadly, which is you now live in a box. You inhabit a box that you didn't necessarily sign up for as a person. And this box now means something about you. And that might be the most powerful and challenging concept of them all. So I agree with Kevin in saying that all 3 of these forces are very psychologically powerful. And for those of you who have heard me on this podcast before, you've heard me talk at length about how important it is for professionals of all kinds to do this thing called informed consent, to speak at length about what you think is going on, how you think you can help, what you think the mechanisms of change are, and all this stuff. And I'd just be willing to doubt that the vast majority who prescribe, the doctors that prescribe, which are mostly GPs in the United States, not even psychiatrists, don't do informed consent correctly because they don't have a thorough understanding of these drugs they're prescribing. Now, the second thing that Kevin said in that little paragraph at the end of his tweet is, if you play along, you are the ball stuck between the three sides. Hey, Darren, good to see you here. There's only one answer. Recognize that it's a construct, and when you do, you can start to heal it and tear it down. So tearing down the construct of mental illness is what Kevin ends his tweet with. And I would like to say something a little controversial, which is, I don't want you to deconstruct anything if you're a patient. I think that that's a silly way to approach what you're experiencing because people are too complicated, in my opinion at least, to think that a particular construct matters or does not matter, in the sense that it's kind of absurd that you care that much what the label is, both as professionals and patients. So I don't want you to deconstruct anything, in my opinion. What I want people to do when they're suffering is to try to understand the layers of complexity of their suffering. Who gives a shit what the doctor labels you with? It's been in my career the case that a lot of people want a label or attach to a label or don't want a label. And in 0% of those cases do I actually genuinely care what the label is. And the reason's because, and maybe that's malpractice, I don't know, but I just think that it's insanely complicated to be a regular person, let alone a person who's struggling. And so the idea that if we put all this weight on this label called major depressive disorder, severe recurrent, for instance, and that label seems to fit and is valid both from the patient's perspective and the doctor's perspective, that doesn't mean that that is all that is happening in the person's life. In fact, I would be willing to bet that there are so many layers of complexity to that person diagnosed with major depressive disorder, severe recurrent. And so that formal diagnosis does not capture their family systems issues, their issues with their romantic partner if they have one, their terrible relationship with food and drugs, for instance, is often the case when people are mentally ill. So there's so many things that people do not actually take a look at and consider, so many layers, that caring about the diagnosis is actually kind of like, I don't know, it just feels masturbatory to me. It seems like a Twitter thing, not a real life thing. I understand that people have been objectified and harmed by people who put them in a box. So I'm not saying that doesn't happen. Hey, Inspired by Reason, glad you're here. So I'm not saying that the label is completely useless or something. And I'm not saying people haven't been hurt by labels. What I'm saying is when that is our primary focus, both as professionals and patients, then I think we are missing the humanity of people, and that is a problem. So I don't agree with this idea that Kevin has, which is we should fight back against the evil construct that is mental illness. Because the idea that nobody is mentally ill is absurd. There are plenty of actually mentally ill people, I can tell you. Angie said, and I'm so glad you're here, Angie. This is exactly what I was hoping for, so thank you for chiming in, because this is what I was hoping I would hear. Angie said, and I think this is reasonable, so let me just give this preamble with I think this is reasonable before I push back on it. So here's what she said, and I quote, patients should deconstruct where and how those labels were created. They have a right to know that. So I want to disagree with the first sentence, and I want to agree with the second sentence. So the second sentence is they have a right to understand where and how those labels were created. And if you mean by that, Angie, like in the room when the doctor gives you the label, sure. If you mean historically, where do the labels come from? That seems like intellectual masturbation to me. Because most of the psychiatrists don't even understand shit about where these labels come from. They've never read, the reports between French neurologists in the 1700s and 1800s where they're talking about that. So I don't think understanding historically where the label comes from is very useful. I think understanding in the room why the doctor gave them that label, that's perfectly valid, for sure. So I agree with that if that's what you're trying to say. and Angie also added a second thought here, which I think is important, and again, reasonable, even though I might disagree. So she said, you're assuming that the average patient understands that the label is not their identity. They don't know that. So to me, that seems like mind reading, right? So I know that some people, see, this is the thing is, I think people are different, right? There's different types of people. I don't think it's all or nothing. I think there's a group of people who walk into a psychiatrist's office or a GP's office or a psychologist's office like mine. They talk about a potential label, and that does become either their entire identity or a piece of their identity. So I think that that's true for some people. I can also tell you, Angie, from like 16 years in the industry, that there are plenty of people who walk into the rehab I'm working at, the clinic, the private practice office, whatever it is, and they have zero care for whatever label they think might apply. They don't care. There's plenty of people who don't care. Some people are anti-labels, as you might imagine. So I don't think it's a one-size-fits-all thing. I think there's certain institutional authority pressure that people will feel. This is what I was talking about earlier. I do genuinely agree that there's a large segment of the population that will feel institutional authority pressure to acquiesce to a label, to agree with a label. I agree. And they might essentialize it. However, there are plenty of ethical clinicians who do not essentialize labels, right? Like I've said many times on this podcast, I couldn't be more grateful for my colleagues at the university where I teach, because every last one of them hates the idea of essentializing labels. Like none of them give a shit about the labels. In fact, most of them are kind of behaviorist types who are like, I don't really care about the label. I care about the behavior and the function of the behavior and what you're going to do about it, right? So I'm very blessed, admittedly, that I get to work with the university and the colleagues that I do, because none of them, who are training future clinicians, by the way, I have the privilege of training future clinicians with these folks, excellent colleagues. And all of them, with different orientations, agree that the label is tertiary to who the patient is. It's not even secondary, and it's definitely not primary. And so I think there are some pockets of people in certain cities and zip codes who are trained poorly, or who are narcissists, which I talk all about on the show a lot, who think that their opinion is godlike, which is absolute crap. There are many people who are like that. However, it cannot just be my university, because I know plenty of my colleagues who are not hung up on labels here in LA. And so I believe that the label problem is only one piece of this. I think the institutional authority problem, where it's like, well, this doctor who I trust because he's a doctor or she's a doctor or whatever, is encouraging me to stick with this medication. That is the bigger concern I have in this conversation. I'm not saying the label problem isn't a problem. I just think that that's a very one-size-fits-all way of looking at that. Some people don't know that their label is not their identity, and some people do. So, but the institutional authority thing, I think, is actually the bigger, more insidious problem, because we take it for granted. I think plenty of us push back on the label problem at the university and the training level. So, just to say, inspired by reason, I see that you're talking about the inner child thing. That's topic number 2. I will get to that probably in about 15 or 20 minutes. So just bear with me. I appreciate that you're sharing and commenting, but you're like 20 minutes ahead of me. So, but again, back to the psychiatry and psych meds thing. There are 3 problems. There's the institutional authority of the person, the prescriber, the psychiatrist. There's the institutional authority of the drugs and how helpful and effective they are, marketing-wise. And then there's the authority of the label piece, right? You're going to hold on to your seat. Good. So the label piece is actually the least toxic part of this, even though it is a problem that I've spoken about on this podcast before. In my opinion, if we're talking about the problems with psychiatry and prescribing more generally, obviously the biggest problem is we have so many primary care doctors and other people who have no psychiatric training prescribing medications. That's horrendous. But number 2, most psychiatric training programs really suck at looking at the entire complexity of a person, right? They don't learn family systems approaches to psychopathology and understanding illness and things like that. They also have very outdated notions of what illness are in many programs. Not all, but many programs. So I see the authority of psych meds being the second worst problem and the authority of psychiatry being the worst problem of these three things that Kevin Roy is talking about in this tweet. There are plenty of good psychiatrists. I happen to have the privilege of knowing a few here in LA, but that doesn't mean that most of them are like that. I would be willing to bet that most of them are mediocre, not particularly interested in how the brain actually works, not particularly interested in how the drugs actually work in full detail. You're here, Phil. That's all that matters. Glad you're here. So these people are the biggest problem, right? The people pushing the drugs are the biggest problem. I also think that the psychiatry industrial complex is secondary to the psychopharmacology industrial complex. But we haven't gotten to that critique yet. I just want to spend a bit more talking about psychiatrists and psychiatric nurse practitioners. I had the privilege of training with some of them and training a few psych nurses myself and working alongside them. Some of them are just well-meaning people who are trying to do their job and not intentionally trying to hurt people and are not serious, terrible narcissists, etc. They're trying to use quasi-broken solutions for people who are badly struggling in serious ways. And I've also had a convenient sample of a life, for those of you who don't know, working mostly in acute, very, very acute care, right? Psych hospitals, drug rehabs, things like that. People who are like acutely, badly, miserably suffering. So my experience is that dynamic is different than the outpatient dynamic where you go see your doctor once a month or your therapist once a week, right? So in my experience, in those segments of the world, there are different approaches than you go see your lazy psychiatrist once a month, etc. Now, some psychiatrists are good people, just to be clear. Some of them are not. I think it's a very mixed bag, and some of them are extremely well trained, and some of them think they're God. And it's hard to find quality professionals in the entire mental health industry. It's not like it's easy to find good therapists, psychiatrists, counselors, and coaches. Finding actually ethical people is extremely rare because they don't teach you integrity in graduate school. Like, I really appreciate my colleague who teaches ethics in my university because I trust him implicitly. He is one of these people that is so masochistically created that he would lose his mind if he taught ethics incorrectly, basically. So he's a good guy, and he will teach ethics in a way that I think will help people protect the public, not hurt the public, right? But that's not the case for a lot of people in graduate psychology, let alone psychiatry. Having a fully informed consent conversation is extremely rare. Spending more than 5 minutes on informed consent seems extremely rare in most settings that I find myself in. And I don't think it's unique to me. So that is a problem, but that is a training problem and that is a culture problem. Okay? So I agree with Kevin that all three forces are a problem. I think the most insidious and problematic version of it is the training of psychiatrists. I think the second most problematic variable is the, let's say, unearned authority of the psychiatric medications and the systems that drive them. And number three is the mental illness box problem. That's my approach. You can disagree with me. If you have a different opinion, I welcome it, but that's where I'm at currently. So if you want to chat, feel free. I have a second tweet that I want to talk about with regard to meds. And this goes into specifically problem number 2, which is, in what ways are psych meds useful and in what ways are psych meds not useful? So I'm going to lay out a very broad paradigm. And for everyone who wants to sue me or cancel me, just know that I also teach psychopharmacology at the graduate level. So future clinicians who are licensed MFTs, doctors, things like that, they have to have, like psychologists, all of us have to have a psychopharmacology class, at least one. So I get to teach one of those for master's level students. And I've been doing that for years. So what I'm about to say comes from my experience teaching those classes, not just some willy-nilly opinion because I hate meds or I love meds, just so we're clear. Okay, so this is a post I made on May 1st, and I want to talk about it because I think it's probably more contentious but extremely important. Oh, Angie, you agree? Good. I'm glad we agree. Great. Okay, so okay. So this post that I made on May 1st, I'm just going to read it in case you're not on Twitter and you're not following me. Short-term, unearned authority, short-term studies, exactly, 100%. So, now this thing I'm about to say, Angie, I don't know if you'll agree with me or not, but I'm very curious to hear what you say. So, on May 1st, Dr. Roger McFillin, who I've talked about on this podcast before, who I have some agreement with and lots of disagreement with, made a post that I responded to. So let me read his post and I'll read my response. He said, public service announcement. And by the way, his handle is at DRMCFILLIN, Dr. McFillin. So he said on May 1st, public service announcement. Medication treatments for anxiety will ultimately make the condition worse in the long run. This is indisputable. Okay, so he said, taking psych meds for anxiety will worsen these disorders. This is indisputable. You cannot dispute it. So here's what I said in response to his tweet, which is going to apply to multiple different psychiatric conditions. So here's what I said. Same day retweet. Medication approaches are, in quotes, avoidance approaches. And avoidance maintains and usually worsens anxiety disorders. So for those of you who are new to clinical psychology or have never talked about this and never learned about behaviorism and things like that, it seems to be a truth. If you read the research in cognitive behavioral therapy, acceptance and commitment therapy, even psychodynamic psychotherapy is built on this premise, even though they wouldn't state it this way. So pretty much all types of psychotherapy, the most effective psychotherapies that have ever been created on the planet, all operate on one general principle. Okay, I'm going to say this again very slowly so I'm not misconstrued. All therapies, all psychotherapies that are effective are built on one general principle. And that general principle is learning to tolerate things you do not want to tolerate. And I'm just going to name a few psychotherapies that are very effective, that work consistently across ages, genders, and cultures. All of these therapies help you learn to tolerate something that you find intolerable. So for instance, acceptance and commitment therapy is about using mindfulness, cognitive flexibility, metacognition, and all sorts of things to become more accepting of your present moment internal experiences and external circumstances. That's all it's doing. And you're working with a professional with your values and all these things in self as context to literally look at your present moment experience and accept it and tolerate it more. So you are consensually learning to tolerate your present moment experience. CBT does the exact same thing with slightly different language and mechanisms. Psychoanalytic therapy is helping you tolerate quote unquote pieces of yourself, and I'll get to the inner child bullshit soon, pieces of yourself that you are not interested in being aware of, right? So if you have a lot of defenses, to use psychoanalytic terms, around trauma, shame, narcissistic injuries, whatever it is from the psychoanalytic perspective that you cannot tolerate or see because of your defenses, then what analysts help you do is learn to see these things and tolerate these things and quote unquote integrate them, which is just another word for tolerating. So I went through psychoanalytic therapy, psychodynamic therapy, CBT, and ACT, three of the most popular types of therapy. Also, ERP, exposure and response prevention for OCD and PTSD, works great. ERP is phenomenal for OCD. It's like one of the most effective things that's ever been created. Now, it's short-term studies, like Angie said, but it's very effective. And ERP exposure, which is learning to tolerate things you do not want to tolerate, right? All types of quote-unquote trauma therapies, EMDR, exposure therapy, virtual reality exposure therapy, CPT, narrative therapy, these are all mechanisms for tolerating distress and tolerating unwanted experiences. So pretty much all types of psychotherapy, in summary, are attempts at learning to tolerate what you find intolerable. I hope everyone understands what I'm saying, because I teach about this for a living. I don't think I'm like exaggerating or overselling or underselling something. I think this is a pretty fair summary. And if you're out there and you disagree with me, let me know if I'm being overly simplistic about this. Darren McGee, another clinician out there, says, face what you fear in small, safe doses with intent. Exactly. That's what all good therapy does, no matter what the language or fancy terms or whatever bullshit makes the therapist feel good about themselves, that makes them feel special. So all psychotherapy is helping you learn to tolerate things that either you don't want to tolerate, you don't want to see, which is another way of saying, I don't want to tolerate it. Right? Now, let's get to my post. I said, and I quote, medication approaches are avoidance approaches. And avoidance maintains and usually worsens anxiety disorders. That's a verifiable fact. If you look at any of the conceptualizations of OCD, PTSD, anxiety disorders, literally, the research shows the more you avoid, the worse the disorder gets. That's a verifiable fact. Now, if we go back to the first statement I made a very oversimplified statement, so feel free to sue me or fire me or whatever for it. Medication approaches are avoidance approaches. Now, this is admittedly a very simple way of looking at psychiatric medications. I can tell you very complicated things about how certain psychiatric medications work on your histamine receptors and what it's doing in theory if they work on your histamine H1 or H2 receptors, or if they work by blocking, antagonizing your D1 or D2 receptors. I can explain to you in some reasonable detail, in a somewhat understandable way, what is generally happening in different parts of the brain when you antagonize these receptors in these pieces of the brain. Most people don't want to know. I've never talked to a patient in my 16 years who wants to know specifically, well, Seroquel works on your H1 and H2 receptor, and so what does that mean? I have never in 16 years had a patient give a shit about the 17 different types of receptors that Seroquel works on. Never once. Never once. And the reason they don't care is because they don't know, number one, to care. Number two, the people prescribing these medications couldn't tell you the substantial difference between your H1 receptor, where it lives in the brain in general, number two, the H2 receptor, what that's doing, etc., and the ways in which these things affect your mood, arousal, attention, and memory. Right? They can speak generally, as most of us can in the profession. But understanding sedation because of your histamine receptor is different than understanding a lack of excitation because you're antagonizing dopamine. Those are not the same thing, for instance. And most doctors kind of understand the difference and can kind of vaguely speak to it, but they're not going to talk to a patient who's worried about taking psych meds and spend 45 minutes explaining the differences between D1 and D2 and your ventral striatum and your prefrontal cortex and your anterior cingulate and all these things. They're not going to spend a lot of time talking about that because there's no reason to, number one. Number two, most people don't actually understand the complexities of these two types of receptors I just named in the different places that they live, so to speak. So all this complexity is mostly intellectual masturbation that I just did. Mostly. Here's what I'm going to tell you. Some medications make you more focused and alert. Some medications make you more sedated and less aroused. When you're using medications to make yourself more sedated and less aroused, that is avoidance, right? Behaviorally, at the simplest level of analysis, that is avoidance. And so for disorders that are anxiety-based and trauma-based, avoidance perpetuates the illness. For disorders that are not anxiety-based and trauma-based, avoidance can be sometimes useful. But even depression disorders are also avoidance-based in a behaviorist sense. So for the most common conditions that people struggle with, avoidance is the problem. And so when they take medications that increase avoidance, they get worse. I'll just give you an example. I moonlight for a sleep clinic from time to time, and one of my patients takes this drug called Ambien. And Ambien is a known sedative, hypnotic, that doesn't quite work like a real benzo. It's a non-benzo of sorts. And it has a very obvious sedating effect for most people who take it. And it works very consistently in sedating you and making you pass out and fall asleep for most people. And for some people, it even helps them stay asleep. So for some people, it's very effective at helping you fall asleep and stay asleep when you have insomnia. But this patient was telling me, I'm worried about taking it too much because I know that will keep me in avoidance. And this is without me actually giving him the spiel I just gave all of you about avoidance, to be clear. So he already knew that he doesn't want to engage in avoidance behavior because he knows it will make his stress and distress tolerance worse, right? So I trust that many people will understand the problem of avoidance. Psychiatrists will sometimes understand the problem of avoidance. But sometimes psychiatric medications, like antidepressants, sometimes, I'm being very intentional here, sometimes antidepressants are used as avoidance mechanisms, avoidance of misery, avoidance of pain, avoidance of self-hatred, avoidance of low mood. And sometimes that is a problem because it keeps people stuck in this place of low self-efficacy and they never learn to tolerate and deal with the pain, so they stay on psych meds forever. However, I can give plenty of examples in my career where, thank God, these people had antidepressants because they were in miserable shape and they could have died. So I am not saying that avoidance is universally evil and psychiatrists are evil. What I'm saying is it is very complicated to understand when and how to use tactics that are like avoidance with psychiatric medications. Another easy example that is very crystal clear in the psychiatry literature, to my knowledge, as a person who teaches psychopharmacology at the graduate level, feel free to sue me, is that when you have panic disorder, and I live here in LA, right? And so just imagine someone driving on these big superhighways like the 101 and the 405. Imagine someone who has a horrible case of severe panic attacks, and imagine they're driving while one happens unexpectedly. That is the most dangerous time to have a panic attack. I sincerely hope that they have something like Xanax, a benzodiazepine, which is very dangerous and very habit-forming, in their center console or something to take the Xanax and then pull over so they don't die. I want them to have a psychiatric medication like that, if it's possible, if their doctor will prescribe it to them, because I don't want them to die. Because in some cases, severe panic can actually put you at a risk of getting in a terrible accident, right? And so I always use these examples when I teach psychopharmacology because there are obvious reasons why certain psychiatric medications are so useful. Another example that I'm probably going to get hell for, but I think it's reasonable, which is I have worked in psychiatric hospitals before. And when someone walks into a psychiatric hospital, and I'm not saying that this is a simple scenario. It's an admittedly very complicated scenario. But if you walk into a psych hospital because you're being dragged there, because you're out of your mind, and you're responding to internal voices that are telling you to hurt yourself and other people, I want you drugged up. I really do. If I'm in that psychiatric hospital and you're responding to internal voices that say, kill yourself or kill somebody else, I really desperately want you injected if you're not willing. If you're willing to orally take a medication that will sedate you so you don't hurt yourself or other people, I really badly want you on a medication in that particular scenario. Because I don't want you to die and I don't want you to hurt somebody else. Right? So these are three exceptions that I think are more than reasonable. Now, if anyone, Angie, etc., wants to disagree with these exceptions, I'm all about the disagreement. But I have never seen somebody who has command hallucinations get better because they were talked to nicely. in my life. Yeah, Thorazine. Now, Thorazine, I think, is particularly dangerous, but it works. It's very effective, but it's very toxic. So for me, I try to be a practical person when it comes to a conversation around psychiatric medications. Is there some short-term temporary use for these medications? Often. Is there a long-term use for these medications of different kinds? Sometimes. Sometimes. It's a cost-benefit question. It's a risk-reward question. It's a trade-off question that every doctor should be having with their patients. And when I, as a psychologist, am asked by a patient or a graduate student about this, I tell them the exact same thing, which is it's really complicated. Can we talk about all of the potential trade-offs? That is what I think we should be doing. So Angie responded, and I think it's worth giving her response some space here. She said, and I quote, "I think people don't have the skills, families, and communities that don't have the capacity to help people in states like that. However, the treatment you suggest are often traumatizing." I completely agree. I think it's often traumatizing for both the individual and even the provider, right? I think it's not weird or unusual to say that. So for me, when you have to forcibly medicate somebody against their will, like in a psychiatric hospital, it is often traumatizing. Some of my patients are not traumatized by it. I've talked to a few that weren't. I've had one person that have ever, and this is, I will tell you, the worst thing I've ever done in my career. I've done two things in my career that I think are absolutely soul-crushingly terrible for anyone to experience if you're in one of the helping professions: medicine, therapy, psychiatry, coaching, counseling, whatever. So one thing that I have done, which I hope I never have to do ever again, but I have done, is I have made a call to a family member to let them know that their loved one has passed. Now, I have been lucky, I believe it's just luck, that these people have passed after they were in my care. That being said, it's still one of the most horrible things you will ever do is call a family member and let them know their kid died. It's the worst thing. The second worst thing I've ever done is one time, and only one time, while I was an intern, I had to hold somebody down where they were injected against their will in a psych hospital. Worst thing in the world. It felt terrible at the time because I know it's dehumanizing and there's no piece of me that wanted to do that. But this person was going to literally hurt somebody in a terrible way. Not like, yell and scream at somebody, but like physically try to kill somebody. So like, I never want to do that again, which is why I don't work in psych hospitals anymore. I never want to do that. I just never want to do that. And thankfully, that's not the majority of people in psych hospitals. So I agree, Angie, that it is traumatizing for some people, and it can easily be traumatizing and not recommended or recognized. So the important thing is having crystal clear boundaries around what are the use cases for these medications on a short-term basis and a long-term basis, and being very clear about the real obvious risks, short-term and long-term, of medications. And so my hope, and I have no clue if this is going to happen, I don't have any idea, but my hope is that the MAHA folks or whoever, or RFK or whatever, will have serious conversations with professionals who can talk about the short-term and long-term risks and benefits of these substances, both from the literature perspective and from the lived experience perspective of patients who have been on them. I want all the data possible to come into the conversation so that people can have real informed consent conversations. So my biggest problem with Kevin Roy's tweet is I don't think professionals are having appropriate informed consent conversations. And that is the biggest sin, I believe, of my profession and psychiatry. I believe. Angie says, I like Getch's point of view. Help people sleep, short-term use, prevention. Society needs to change this problem. Yeah, like prevention is one of the most important things on the planet. And if I could get someone to pay my way, I would only do prevention work. I would exit my life consulting right now. Like if I could get like a Peter Thiel type or whatever to fund my prevention efforts, I would do that tomorrow. And I could actually help people with prevention. Prevention is not magic, but prevention campaigns are done terribly by the government and terribly by institutions like universities. The prevention campaigns at most universities are horrible because they're made by clinicians and social workers who know nothing about the research on prevention. They just know politics and they know it's trendy, but they don't actually understand what the research actually says about prevention. So it's very, very important, extremely important to do prevention correctly. I agree with you, Angie. So, in summary, what I will say about psychiatric medications is sometimes avoidance approaches are very useful because they will keep you alive temporarily. And I'm all about that. I couldn't be more in agreement with that. I'm all about people not dying. I'm all about people getting stabilized short term. Long term, it becomes insanely complicated, in my opinion, because people's lives, families, communities, as Angie said, are complicated. Many people do not have the psychosocial support they deserve to actually learn how to heal from shame and trauma, childhood stuff, recent trauma, pressure by family and friends, pressure from authorities. There's so much pressure that people face, especially once they're in the industry, once they're in the institutions. And navigating that effectively and ethically is hard, admittedly. So that's why I take my job as a professor extremely seriously, because I want to try and influence the next few generations of people to be as ethical as possible and as reasonable as possible when it comes to having these conversations around psychiatric medications, informed consent, ethics in treatment, short-term and long-term pros and cons of different types of therapy interventions, medication interventions, psychosocial interventions, family therapy and systems interventions. Everything matters. And so I'm blessed and very privileged to work with my colleagues that I work with, because I know we're doing a good job of talking about all of these layers, whereas many universities do not do that. And I think it's malpractice that it's not talked about more, especially like in graduate training, family therapy, family interventions, systems therapy, systems interventions, prevention. I always talk about prevention in my classes. I spend a great deal of time talking about it, but that's not part of standard curriculum in most classes. So prevention is far more important. And if I could get paid to only do prevention, I would do that tomorrow. No question. So thank you for all the comments. Edmund says, do the same drugs that help people avoid harm prevent the toleration of therapies? Yes. Yes. So one of the major problems with psychiatric medications for many types of psychiatric conditions is that if you're trying to do some kind of exposure work with people, those psychiatric medications will not allow you to feel the intensity of the emotions as strongly, which means that you're not getting a very raw experience of the feelings. So yes, Edmund, you're correct that one of the problems with psych meds is if you're trying to do good therapy, where you're learning to tolerate yourself and your feelings more, if you have psych meds making you numb, if you have psych meds making you artificially less anxious, then you are not getting the full benefit of the psychotherapy. You're still getting some benefit. It's not all or nothing, but you're not getting the full benefit of that experience, which might extend therapy. So the other problem is psych meds will make you in therapy longer because you haven't learned how to tolerate the distress as quickly as if you were not on the psych meds. That being said, some people are so disadvantaged. Some people have no resources. Some people have no friends. Some people have no family. And so sometimes being in therapy longer is okay. And sometimes learning to tolerate distress over a longer period of time is okay because they are so traumatized and they are under-resourced, right? So I'm okay with that on a case-by-case basis. But I'm always wary of the idea that people have to be in therapy forever. Because you can probably tolerate more distress more quickly with the right professional and the right psychosocial resources if you have them. which not everyone does. Okay. So that went on way longer than I anticipated it going on, but good comments, good chats. Thank you, everyone. I hope all that makes sense, and I appreciate any and all disagreement. Sorry, that you will have. So, speaking of avoidance, I want to end today's podcast talking about this. Okay. So I will get to the topic that I said I had 3 topics today, which is psychopharmacology and medications, inner child, and what to do with unwell professionals. I will spend next week's podcast talking about what to do with unwell professionals because we're not going to have enough time today. Jeff says, a lot of people are tuning into YouTube and social media as those resources. Well, Jeff, if you want to send them my way, I'm happy to be a resource to the extent that I can be. But we need real life people to be our resources. We need good families and friends. We need more of that. So let's end today talking about ye old inner child. So I've talked about this before on the podcast, but let's talk about this. So I don't know what to tell you guys. We have a problem. And by the way, this post that I'm retweeting is from someone I like named Franny Fanny. Her name on Twitter is @ProudPenelope, proud_Penelope. So here's what she said. I have a Substack out on the overuse of the nervous system and all that stuff. And it's a great Substack. I think you should definitely check out her Substack. So here's what I said. Inner child talk is avoidance of responsibility. Excusing your behavior with therapy speak is an example of how the profession is harming society. We have to be able to own our more selfish and reactionary tendencies. So again, this was what I posted yesterday. Inner child talk is avoidance of responsibility. Excusing your behavior with therapy speak is an example of how the profession is harming people. We have to be able to own our more selfish and reactionary tendencies. Jeff says, I'm looking for my inner adult. Yeah, me too, buddy. I can't find him for some reason. Darren, very insightfully, says, the inner child doesn't always need healed. Sometimes they just need to let out play once in a while. Yeah, thank you for saying that, Darren. So, first, from a technical perspective, there is no inner child. I don't know how else to tell you guys this, but there is no such thing as an inner child. There are 0 brain scans that look at our memory systems that can find some piece in your brain, in your temporal cortex, your mid-cingulate gyrus, your amygdala. There's just no part of your brain or no set of networks in your brain that signal a so-called inner child. It does not exist. It will never be found. I'm just 100% certain of this. And my God, I will donate $1,000 to your favorite charity if we finally figure out conclusively that everyone has an inner child. If it's ever discovered, I will eat my hat and I will donate $1,000 live on the air to some charity that you think is important. But I just cannot imagine it will ever be real because it's not a coherent concept. It's bullshit. It's marketing. It is a way to talk metaphorically about a complicated set of internal experiences. It's a bad metaphor. And when I say bad metaphor, it's a useless metaphor. It's a metaphor that oversimplifies complicated feelings and wishes. Edmund says there is a segment of memory frozen by trauma from a child. No, there is not. It is not frozen. The memory is not frozen. The memory might be a little rigid or might be experienced rigidly, but is not frozen. That's catastrophizing language. So all of these oversimplified notions are absolute horseshit. People are complicated. Remember how I said that just 10 minutes ago? People are complicated. And when we treat people with respect, we see them in their complexity and we do not oversimplify their suffering. So you might have been traumatized as a child. you might have experienced, let's say, you might have experienced neglect as a child. You might have childish wishes as an adult. So for instance, you might have been so neglected at the age of 2, 3, or 4 that your primitive, childish, infantile wishes didn't get very attended to as an infant and a young child. So therefore, those needs never got met. And so maybe they show up as an adult. But that is not the same thing as having an inner child. You never learn to tolerate those feelings and urges, which is different than there's this metaphorical concept, there's this template, there's a schemata in my brain that I can see and deal with, which is just not true. And so most people, in my experience, who talk about inner child are trying not to take responsibility for how they feel and how they act. My inner child made me do it, which is horseshit. What is true, technically, is that the complicated reasons why we react excessively include unmet needs from childhood, but it's not just unmet needs from childhood. It's also situational stressors. It's also a lack of compassion for the person sitting across from you that you just vomited on, and all these things. So there's 6 or 7 things happening in any particular interaction where your so-called inner child shows up. So the people who oversimplify it to that are avoiding taking responsibility for their behavior, and they're avoiding looking at the complexity of what just happened just now when you wanted to blame your inner child. So it's very, very important, in my opinion, as a professional and as a regular person, to see people as the complex little creatures that they are. Because we all are. Because we are all complex. For instance, as Darren said in this chat here, sometimes the so-called inner child just needs to come out and play, because sometimes when people are doing things that are aggressive or weird or awkward, they're trying to play and they suck at playing because they never learned how to play as a kid, for instance. Or they learn maladaptive ways of playing. Or they don't understand their personality, so they play in a weird way, for instance. It's complicated. Imagine that people are so complicated that using useless metaphors like inner child just oversimplifies people and makes them worse. Yes, as Jeff says, people are complex and individual. So if you're out there and your therapist says things like inner child to you, I hope you at least ask them, what do you mean by that? What are all the layers to who I am as a person? What is my personality like? And you explore those things, because you are complicated and you deserve to be understood in your complexity. If your therapist, if your coach, your counselor, whatever is ethical, they will help you see and gain contact with the complexities of who you are in a way that allows you to feel more empowered, not excuse your behavior. Understanding, insight, knowledge should help you feel empowered, not excuse antisocial or maladaptive behavior. So, that's my little rant on so-called inner child. Well, we've had quite a... Inspire Reason says, my inner child is throwing a temper tantrum at your answer. Really? Why are you throwing a tantrum, little boy? I assume the gender of your inner child. Why are you throwing a tantrum? Tell me. We have a couple of minutes. Dígame. Did your inner child not like what I said? It's funny. So, it's been a bit of an intense podcast today. I greatly appreciate you all being here, chatting, commenting, pushing back Angie and others. I really appreciate it. It means a lot to me. And I think it's good for everyone to hear the thought process play out, because I don't think they hear enough of that from people on Twitter or in the consulting room or in the clinic. Yeah, it's avoidance of certainty is wrong. Exactly. You shouldn't be that certain, by the way, about what you think your inner child is, too. It might be more complicated than you think, too. So I got to wrap it up here, but I really appreciate you all being here. I really appreciate everyone commenting and chatting. and pushing back and exploring and sharing. And if anything you heard today was useful, interesting, challenging, I hope that you come back next week and continue to participate in the conversation. And if you are listening to this after the live stream is over and it was helpful or interesting, please like, share, and subscribe and share with somebody else. Because I believe, at least, that if we get more people having serious adult conversations about these issues, then more people will have a more nuanced view of their mental health and what they're going through. For instance, Inspired by Reason says, your main issue with it is that it's used as a way to avoid, but why could it not be used as a metaphor to engage, say, through self-compassion? It's easier to be forgiving or less harsh to an inner. No, I don't agree. I think that most people can actually be compassionate with themselves as regular adults. I've done it in my clinical practice for a long time now. So I don't think you need some excuse to be self-compassionate. I think that's avoidance. You're avoiding giving yourself compassion by focusing on some metaphorical little thing. I don't agree with that. I think that's cowardice. And I think a lot of people in the profession are prone to cowardice and worrying that people can't tolerate things. But in reality, most people in therapy are not fragile. They're not. So we should not treat patients as if they are fragile, per DBT. So I really appreciate you all being here. Inspired by Reason, Edmund, Jeff, Club Exile, Phil, Angie, Darren, thank you so much for being here. Awesome to have you here. As always, glad you're here. Please like, share, and subscribe. Follow me on Twitter at AlobhaPatrick, at ALOBHAPATRICK. Come back next week, 3 o'clock Pacific Standard Time, and chat again. We'll have some new fun topics. We're going to talk about what to do with unwell professionals, like myself, next time. And I had a joke, but I forgot it, so next week we'll have a joke. See you soon. Take good care of yourselves. Take good care of other people in your immediate environment. Eat better. Sleep better. Move more. Your life will get better. See you very soon.